Overlooking the obvious in heart failure is the topic up for discussion. The topic will be delivered by Dr. V.L. Jayarakash, Head of the Department of Cardiology, Government Medical College, KOTTAYAM. We also have with us the esteemed Dr. Kumar, who was Head of the Department of Cardiology in Medical College, KOTTAYAM, was our principal, was the ex-DME. Sir will be chairing the session. So without further ado, I call upon Dr. Kumar to please begin the session. Thank you, sir.
Thank you, Suvan. Can you hear me?
Yes, sir. Yes, sir. You're audible.
Okay. And now I think there is no need to introduce Dr. Jayaprakash because already his credentials have been shown. The topic overlooking the obvious in heart failure. I have some confusion on this topic. What is the area which we have, but I am sure JP will not have any confusion. JP, why don't you clarify the confusion? What are things which should not be overlooked when you manage congestive heart failure? Dr. JP, please.
Good evening, all. My beloved and most respected Sudhemar sir. At the outset, let me thank Sangamitra madam for giving me the chance to be here and talking with you. The topic you just given to me is heart failure overlooking the obvious. So this was a bit confusing topic. So first thing, whenever I do a talk, I call Sudhemar sir. When it is a difficult topic. So I did first call Sudhemar sir and asked what is the areas which I had to address because it was a perplexing topic. Then sir told some ideas and asked, you ask Sangamitra madam itself. And then I called Sangamitra madam. And although I could get some clarification on this, madam told these are the areas which we are expecting you to touch. So let me talk on what is the obvious which is overlooked. As an introduction, heart failure affects over 38 million people worldwide. It has been shown that 1 to 2% of the adult population may have heart failure. Heart failure is now one of the most important epidemics in the world because we are treated many of the heart diseases and the end stage is heart failure. The lifetime risk of heart failure at any age above 55 years is supposed to be 33% for men and 28% for women. This is, in addition, there is a HFpEF, that is heart failure with preserved ejection fraction, which we previously called as diastolic dysfunction, which is around 22 to 73%. So one can imagine the burden of heart failure in the cardiovascular disease spectrum. Yet another thing is that look at the mortality. The 12-month all-cause mortality rates for hospitalized and stable or ambulatory heart failure patients is pretty high. It is 17% and 7% respectively, irrespective of whatever be the status of the patient. Overall, it is 17% and 7%. So this underscores the importance of the heart failure. And as a prelude, I would say heart failure, we can look into 3 groups. I had already told one is we have HFrEF, that is heart failure with reduced ejection fraction, which is our classical systolic dysfunction, where there will be signs and symptoms of heart failure and LV ejection fraction is less than 40% by any methods. We have heart failure with preserved ejection fraction, that is HFpEF, where there are signs and symptoms of heart failure with ejection fraction of more than 50. And a new addendum to this group is HFmREF, that is heart failure with mid-range ejection fraction, where the LV ejection fraction is between 40 and 49. So basically, we have 3 groups. One is HFrEF, second is HFmREF, and third is HFpEF. And we have now very good methods in diagnosing heart failure also, because a lot of new things has come. The echocardiography has evolved like anything. And we have clinical physical examination and ECG parameters to assess whether there is any probability of heart failure. And if any of this thing is present, one can go for markers. And the 2 markers which has been very well validated are the NT-proBNP, which more than 125 picogram per milliliter, and or BNP more than 35 picogram ml. And this supplemented with an echocardiography, we can say whether the heart failure is unlikely or it is there, or we have to consider other diagnosis. So in the diagnosis, now we are aided with a lot of investigations like natriuretic peptides and echocardiography. And so there is no overlooking in the diagnosis now. Coming to the etiology of heart failure, we have a lot of enormous etiologic categories. One is the disease myocardium, the commonest being ischemic myocardium, ischemic heart disease. Toxic damage of the myocardium as caused by radiation, heavy metals, alcohol, and immune-mediated and inflammatory damage to the myocardium as related to the most of the infections and lymphocytic myocarditis and other things. Infiltrations to the myocardium, that is a malignancy, etc. Metabolic derangements, you have all the hormonal diseases like thyroid, parathyroid, and nutritional deficiencies, and a lot of genetic abnormalities which may be diverse, like hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular dysplasia. And second group of conditions are the loading abnormalities, like hypertension, which is one of the very common causes for heart failure, valve and the myocardial structural defects like any of the acquired valvular heart diseases, congenital heart diseases, the pericardial diseases, high output states, volume overload situations, arrhythmias, tachy and bradyarrhythmia. So etiology itself is diverse in heart failure. So what are we actually ignoring? It is the comorbidities that is being ignored. And when I looked at the literature, there is very sparse literature on the comorbidities addressed in literature. We concentrate mainly on heart failure, the diagnosis, the management, the prognosis, everything. But we overlook the comorbidities, and let us see how it is important. Quoting Aldous Huxley, facts do not cease to exist because they are ignored. These facts are still there, and we have to be aware and we have to see these facts. If you look at one of the largest studies, there are very sparse literature on the comorbidities in heart failure. One is a cardiovascular health study which was published recently. It has been shown that 60% of the heart failure has more than 3 comorbidities. So look at the magnitude, 60% of the heart failure has more than 3 comorbidities, and let us see what are the comorbidities. Hypertension is the commonest comorbidity in heart failure. 82% of the heart failure patients combining systolic as well as diastolic, that is HFpEF and HFrEF, has got heart failure. Another 59%, it is coronary artery disease, and diabetes is another comorbidity. Around 30% of the people have diabetes and chronic kidney disease. Neurological diseases, especially CVA, around 20% of the people have CVA as a comorbidity in a heart failure. There can be obstructive airway disease in another 20%. And so a lot of comorbidities are there, of which I will tell it is hypertension, coronary artery disease, diabetes, and CKD and the CVA, which are in the order of prevalence. Why these comorbidities are important? Why should we be looking at them? It is all this. It is actually not the heart failure per se that contributes to the mortality. It is significantly mortality is contributed by these comorbidities. For example, these are the features which the comorbidities are increasing the mortality. Low body mass index, diabetes, chronic kidney disease, cerebrovascular disease. These are the things which that really increase the mortality in heart failure, and some which can cause morbidity and can affect, but not to such an extent, is the hypertension, coronary artery disease, atrial fibrillation, and the obstructive airway disease. So we can look into the 2 groups, one which really bothers us in mortality, and the others which may be important in the morbidity, but not too much contributing in the mortality. And if you look at, we can see that the high mortality among the elderly persons with incident heart failure is 19% at 1 year, 56% at 5 years, and 83% at 10 years. And it is in part attributable to the cumulative impact of the key morbidities. So I would underscore that the mortality as well as morbidity in heart failure is there, but it is more important to look at the comorbidities, which are very important addendums to the mortality and morbidity. One of the important comorbidities, I would say, it is anemia. Although it was not addressed in many trials I had shown, anemia is the important association with heart failure. It is associated with the worst prognosis. It is more common in women and elderly and in patients with renal disease. It leads to myocardial remodeling, inflammation, volume overload, and worse functional status. There is greater risk of hospitalization and reduced survival has been seen in many trials where anemia is one of the comorbidity. And patients with iron deficiency need to be screened for any reversible causes and none of the important things, because most of these patients will be on aspirin and other anticoagulants. Gastrointestinal bleeding is one of the important causes for anemia in heart failure. The prevalence in the multi-ethnic Asian heart failure study, it has been shown that as high as 50% there is anemia as a comorbidity in heart failure. And in the incidence of cardiorenal anemia was around 27%. And this anemia adds on to the higher odds score, all-cause mortality in acute heart failure also. Malnutrition in heart failure is another important factor contributing to anemia. And as you look, as the NYHA class in heart failure increases, there is a steady increase in the prevalence of anemia also. So if you see here, class 4 heart failure patients, there is higher incidence of anemia. A lot of mechanisms are there for anemia in chronic heart failure. I'm not going to the details. It may be hemodilution, it may be renal dysfunction, what is a cardiorenal anemia, one of the important factors. It may be inflammation caused by many of the inflammatory molecules like tumor necrosis alpha. It may be iron deficiency, one of the important cause, which may be contributed by many mechanisms. I have told one, which is occult bleeding as well as malnutrition. Chronic heart failure can suppress the bone marrow, as well as the drugs like ACE inhibitor have some suppression in the bone marrow and reduce the hematopoietic progenitor cell that can lead on to anemia. So anemia in heart failure is multifactorial. And what are the management options? What about transfusion? Transfusion should be reserved for severe symptomatic anemia patients in heart failure because the data is very limited. And transfusion therapy has shown only temporal benefits and adds a lot of additional risk in patients with heart failure, such as volume overload and ischemic events. 2 studies concluded that patients with heart failure who received blood transfusion had worse prognosis and clinical features. This was contributed by many mechanisms like hemolytic reactions, infection, acute lung injury, allergic reactions, and it is a guideline recommends to restrict transfusion only in anemia if there is heart failure patient with anemia if the hemo. And second molecule which has been tried in anemia with heart failure is darbepoetin, which is so it is the red heart failure trial, which is it was a large trial which has shown that darbepoetin alpha compared with placebo, there is no benefit with darbepoetin. Actually, it was shown that there was an increase in the composite endpoint of death as well as worsening of the heart failure when patients were put on darbepoetin. So this is not also recommended in patients with anemia and heart failure. Why there was an increase in the events? Because of the increase in the thrombotic and embolic events. So darbepoetin arm had an increased mortality, and this has led to the safety outcomes. And after the red HF trial, it is recommended that this is not a choice in a patient with anemia and heart failure. Now coming to iron as a treatment in heart failure, we have oral as well as IV iron. Oral iron has been we use in the ferrous form. It has been tried in many trials, iron HF, iron out HF. A lot of trials are there. I'm not going to the details. And it has been shown that the data is not very good. There is no improvement in any of the parameters like oxygen consumption or a 6-minute walk test with oral iron. Although in some of the trials there was an increase in the mild increase in the parameters, there was no definite improvement in any of the outcome parameters. And now we have intravenous iron, that is ferric carboxy maltase. It has one of the good molecules which has been tried in heart failure. We have a lot of trials. One is the FAIR-HF trial. And after this trial, it has been shown that there is a significant improvement in the primary as well as secondary endpoints in patients with anemia of different grades. And the primary endpoint was a self-reported assessment, global assessment, and the secondary endpoint was an NYHA class and 6-minute walk test. Both had a good statistically significant improvement. And after this trial, the ferric carboxy maltase entered the recommendations of the ESC guidelines in treating patients with anemia and heart failure. Other trials also confirm this, confirm, and the EFFECT trial also confirmed that the ferric carboxy maltase is a good molecule to treat the anemia in heart failure. And this is one of the recent meta-analysis where ferric carboxy maltase was looked for outcome in patients with anemia. From this graph, we can see that the cardiovascular hospitalization frequency and cardiovascular mortality was significantly lower in the treated group with ferric carboxy maltase compared to placebo. The heart failure hospitalization and cardiovascular mortality was lower. The cardiovascular hospitalization and all-cause mortality was lower. So all the primary and secondary endpoints were significantly reduced when these patients were treated with intravenous ferric carboxy maltase, and that is why the both American group and European group now recommends ferric carboxy maltase intravenous as a treatment of choice in patients with anemia and heart failure. And for Europeans, it is class 2A, and American society, it is class 2B indication. There are a lot of novel approaches which are coming in treatment of anemia with heart failure. We have hypoxia-inducing factor stabilizers like roxadustat, then erythropoietin mimetics. We have hepcidin inhibitors. So a lot of new molecules are coming. All are under trial. So I would conclude, and anemia treatment, it should be with intravenous very-carboxy maltase, and no other data for any of the other molecules. The second important, I would say, one of the most important comorbidities in patients with heart failure, more so in HFpEF, that is heart failure with preserved ejection fraction, is hypertension. It has been shown that in the study, it is around 80 to 85% of patients with heart failure is having hypertension. And hypertension itself, there is an increased risk of developing heart failure. So it is, both are interrelated. Higher the baseline systolic, diastolic, and pulse pressure levels associated with the higher rate of adverse events. And so optimized blood pressure control is very, very essential in a patient with hypertension. And one more thing, you should not be over aggressive, because one of the problems with hypertension, aggressive management in patients with heart failure, especially in elderly, is cognitive impairment and cerebrovascular accidents, which has been very well documented. So let us see what are the drugs. Alpha adrenoreceptors, we have less effective in progression of the heart failure. And also we have some of the data like ALHAD trial and all, which has shown that alpha adrenoreceptors are not the choice in patients with heart failure. They can actually increase the mortality. So alpha adrenoreceptor blockers are not the drugs. Of course, we all know that the negative inotropic calcium blockers, diltiazem and verapamil, should not be used. They are contraindicated in patients with HFrEF, but they can be used in patients with HFpEF. Moxonidine, which is a sympathetic outflow outflow inhibitor, has been shown to increase mortality, and so these are not the drugs to be used in patients with hypertension and heart failure. Try to avoid these drugs: alpha adrenoreceptor blockers, the negative inotropic calcium blockers, and moxonidine. Which are the drugs we can use safely? These are the drugs which we all know. It is ACE inhibitors, ARBs, and beta blockers are the good choices in patients with hypertension and heart failure. We have mineralocorticoid receptor antagonists like eplerenone or aldactone, and we have a lot of diuretics. These are the group of drugs which can have a good effect in the morbidity and mortality in patients with hypertension and heart failure. If BP is not controlled with these drugs, these are the drugs which has been shown to have good data, that is italazine and amlodipine. So these are the drugs which one should consider when treating a patient with hypertension and heart failure. One of the controversies is the targets. There is no much data in hypertension with heart failure what should be the target. But whichever data is available, and the societies, both European and American societies, recommend the target BP should be less than 130/80 in a patient with heart failure and hypertension. So when treating, we have to bring down, no doubt the BP should be less than 130/80. It has been shown that they improve the outcomes. But studies have also shown that there can be a Jaker phenomenon in patients with hypertension and heart failure, just like usual hypertension. So it is recommended not to reduce the BP less than 120/70, especially they had shown that there is a higher cognitive impairment and cerebrovascular problems if the BP is reduced to less than 120/70. So I emphasize the target BP should be less than 130/80 in a patient with heart failure and hypertension, and it should not be less than 120/70. So that is something on hypertension, which is one of the important comorbidities in heart failure. Another comorbidity, I would say it is not a comorbidity, it is a cause as well as a comorbidity in patients with heart failure, angina and coronary disease. Very vast topic, I'm not going to the details. Some of the important points, that the drugs of choice when a patient has got angina as well as coronary disease, which has been shown to be having good results, is beta blockers and ivabradine, which has been shown to improve the heart failure mortality also. So two drugs which should be considered are beta blockers and ivabradine. Trimetazidine also has been shown to have exert beneficial effects, especially when it is an add-on to the beta blockers. It has been shown they improve the functional capacity, exercise duration, and LV function. One can consider amlodipine, nicorandil, or nitrates if the patient is having angina despite these drugs. As I told, diltiazem and verapamil are not recommended because of the negative inotropic action. And combination of nicorandil and nitrate is not recommended because of the additional efficacy is not at all there. Very often we combine nicorandil and nitrate, there is no definite data to say in heart failure and coronary disease, there is no additional efficacy. And combination of ivabradine, ranelozine, and nicorandil, they should not be combined because there is a risk of increased mortality when this combination was tried. Of course, I need not say that one should be definitely looking for the chance of myocardial revascularization when the patient has got coronary disease and heart failure. And whether to check for viability or not, it is controversial. Now, most of the authorities think that there is no need to check viability. The patient has got heart failure and coronary disease, and it is revascularizable either by angioplasty or CABG. That should be done. So that is on the angina and coronary disease. One of the important comorbidity, I would say, it is diabetes mellitus, very common in heart failure, and both are interrelated. There is a poor functional status and worse prognosis if a patient has got diabetes and heart failure. And interventions that reduce the morbidity and mortality confer similar benefit, whether it is without heart failure or with heart failure. Not going to the details of vast area, diabetes and heart failure, I would say certain points. One is metformin is one of the best drugs in HFrEF patients with diabetes. Insulin has got a problem because there is a sodium retention property for insulin, and it can exacerbate fluid retention. So insulin should be considered only as a second choice in a patient with heart failure and diabetes, because the studies have shown that there can be sodium retention and exacerbate the heart failure. Sulfonylureas, there is some data to say that it can worsen the heart failure, so they are also not the choice. So metformin should be the choice in patients with heart failure and diabetes. What about the other drugs? The glitazones, that's the pioglitazone group of drugs, they cause sodium and water retention, and increased risk of worsening of heart failure and hospitalization should not be used in patients with heart failure. Pioglitazone or the thiazolidinediones are not at all a choice and not recommended. DP4 inhibitors, gliptins, lot of data is there, but the safety of gliptins is still controversial. And some trials have shown it can worsen the heart failure. So gliptins also is not 100% safe to be used in heart failure. And the most rosy drugs are the gliflozins. We have a lot of data, and I think last CME I had addressed the same thing. Gliflozins has moved from the diabetologist to the cardiologist now. And so this is I know the limitations of gliflozin, but it has been shown that they are good drugs, and our experience with these drugs also states it's a good drug in improving the heart failure, hospitalization, as well as mortality. So I would emphasize the two drugs. One is metformin, and second is all the gliflozins, empagliflozin and dapagliflozin, which are the drugs of choice in patients with heart failure and diabetes mellitus. Kidney dysfunction, we had already heard a lot on the kidney dysfunction, but heart and kidney are two brothers, I would say. Heart failure and kidney frequently coexist and share many of the risk factors, and they interact to worsen the prognosis. They have common pathophysiological pathways, which are like RAS activation, neuroendocrine activation, inflammatory activity, oxidative stress, all are in common pathways for the genesis of heart failure as well as kidney disease. And both myself and Jagamar will be very much worried when there is a worsening renal function in patients with heart failure. More than 25% increase in serum creatinine and more than 20% drop in the GFR is the standard criteria to tell that there is a worsening heart failure. It can worsen the prognosis. Many mechanisms has been there, that the direct consequence of the neurohumoral overdrive, arterial underfilling, venous congestion, pre-existing, all these can reduce the renal perfusion pressures. Pre-existing kidney status is also very important when a patient is worsening heart failure. Our aggressive diuresis can worsen the renal function. Many of the heart failure drugs like ACE inhibitors, ARBs, can worsen the renal function. And sometimes the contrast media which we use for angiogram and all can cause worsen the renal failure. So these are the causes of worsening renal failure and in patients with heart failure. And CKD should be one of the things that most of the trials where this heart failure with CKD as a comorbidity was addressed, they excluded CKD patients. So the data also is not too much in patients with CKD and heart failure. And very often we stop ACE inhibitors and ARBs and MRIs are withdrawn. And this, along with the diuretic resistance, it's a very difficult scenario to manage a patient with heart failure and CKD. And we have different mechanisms also in addition to the cardiorenal syndrome. And high loop diuretics, our first choice will be to go for a high dose of loop diuretics or intravenous loop diuretics, which can definitely cause electrolyte imbalance hypotension, and another risk of arrhythmia is added on. So when high-dose diuretics are used in a patient with chronic kidney disease and heart failure, we have to be cautious because a lot of adverse things can happen and they are at increased risk of arrhythmic death also. Prostatic obstruction is another thing, especially in elderly people with heart failure. It has been shown it can worsen the renal function also. And any patient with not improving with the heart failure, or there is a worsening renal failure, you have to look for prostatic obstruction, especially in elderly males. Alpha blockers are one of the drugs which we use, but it can cause hypotension and sodium and water retention. So in patients with BPH and heart failure, it is not safe to use alpha blockers. But 5-alpha reductase inhibitors has been shown to be generally safe and preferred in patients with heart failure and prostatic obstruction. Another overlooking thing is the stroke. Stroke and heart failure commonly coexist. And the risk of ischemic stroke is 2 to 3 times higher in patients with heart failure. Both in patients with and without AF, it has been shown that there is increased incidence of stroke. Both patients with AF and without AF. Approximately, it is 10 to 24 of patients with stroke or heart failure. And heart failure appears to be the cause of stroke in 9% of the patients. So both are interrelated. And in Framingham study, it has been shown that the risk of ischemic stroke was 2 to 3 times higher in patients with heart failure than those without heart failure. So stroke is another important comorbidity which has to be addressed. When stroke happens or occurs as a heart failure a comorbidity, there is higher mortality rate. There will be more severe neurologic deficits, longer hospital stays, and adding to on this, the silent stroke, which is MRI detected strokes, can be a precursor of larger strokes. And without even without considering this thing is the incidence which I have told. In managing the stroke, one has to balance the risk of anticoagulant and antiplatelet therapies. That is one thing that has to be careful when managing a stroke with heart failure. We have a lot of trials now showing that our NOACs are superior or equally good as the conventional warfarin with a lesser dose of lesser bleeding. And so in stroke and heart failure, I think dabigatran, Rocatinlimab, rivaroxaban, Aristotle, apixaban, NKJ, fedoxaban. These trials has been shown that it is safer to use with heart failure patients with AF, and where it can be a with the lesser risk of bleeding. We have some data with the normal sinus rhythm also. Patients with heart failure and normal sinus rhythm. There has been some data saying that, and some of the trials like some of the trials are ongoing where it has been shown that even in sinus rhythm, there is some role for this NOACs in reducing the risk of strokes in patients with heart failure. So both in patients with AF as well as in sinus rhythm, there is some role for NOACs. Sleep abnormalities and sleep disordered breathing, which common ones are the central sleep apnea, the obstructive sleep apnea, and the mixed sleep apnea. All are common in patients with heart failure. It is seen in around 1/3 of the patients with heart failure. So that is also not an uncommon comorbidity, and it has been shown it worsens the prognosis. And sleep deprivation may be contributed by by many factors: the anxiety in heart failure, the depression in heart failure patients, the decubitous, the PND, our diuretic therapy. Everything can lead on to sleep deprivation, and the polysomnography should be done, and the sleep should be addressed in patients with heart failure. Another comorbidity which is overlooked, and a lot of things has been tried in sleep disordered breathing, like the OSA and all, but nothing has been shown to have an improvement in the outcome in this in heart failure patients. Nocturnal oxygen supplementation. Then we have CPAP, BiPAP, adaptive servo ventilation. None of these interventions has been shown to improve the outcomes in patients with HFrEF and the sleep abnormalities. CPAP has been shown to improve the LV ejection fraction and 6-minute walk distance. But a SERV-HF trial has shown that this adaptive servo ventilation has been shown to increase the all-cause and cardiovascular mortality, and so it is not recommended. Newer techniques for sleep disordered breathing are coming, like implantable phrenic nerve stimulation and all, which are under trials. Asthma and COPD is another thing. There is an overlap in symptoms and signs. There is a problem of interpretation of the spirometry. It can worsen the functional status. And once the patient stabilizes, only spirometry should be done, because otherwise there can be a abnormality in the result. So once the patient is becoming euvolemic and the patient is stable, one can go for a spirometry. Few points I would like to highlight. Beta blockers are only relatively contraindicated in asthma, but not in COPD. And the more selective beta blocker, beta agonist, like bisoprolol or nebivolol, in a small dose can be used in a patient with heart failure and COPD. It has been shown they improve the mortality and morbidity. Long-term inhaled pulmonary drugs, as the effect in heart failure patients is unaddressed. So we don't know whether these inhalers will be good or bad. Steroids, we all know it can cause water and sodium retention and worsen heart failure. And pulmonary hypertension can complicate this issue. So asthma and COPD are also important things in patients with heart failure. Obesity is another thing which is underaddressed. It can cause dyspnea, exercise intolerance, ankle edema, and echo will be poor windows in this. And it is an independent risk factor for developing HF, PEF especially. And one thing is that there is a thing called as obesity paradox, where obesity is found to have, obese people are found to have lesser mortality in heart failure. So when should we advise the weight reduction? It is only when the weight is above 35, the BMI is about 35 to 45, we should advise weight reduction. Otherwise, the obesity is in a way protective. Obese patients may have better care and more aggressive medical care. They may be taking more medical therapy. A lot of reasons are thought to address the obesity paradox. So only when it is more than 35, BMI is more than 35, one should address obesity. Thyroid dysfunction is another common, hyper and hypothyroidism. And thyroid function test should be recommended in any patient with heart failure who is not improving. It should be repeated every 12 months in a stable patient and 3 months in patient with amiodarone. And it should be treated accordingly. So this is another important factor which has to be addressed. So to sum up, heart failure patients have a high burden of multimorbidities, I would say, and we are definitely overlooking that. Many of these add on to the higher mortality in heart failure patients to big extent, and it is not the mortality of the heart failure as such. These comorbidities, or I would say multimorbidities, contribute to the heart failure. And these are the things, the guidelines and studies has not addressed this area. And one should not forget that we need to treat the whole patient rather than, which is always highlighted by Sudhir sir, look at the patient as a whole. Don't look at his heart and treat the heart failure. We have to look at the patient whole, and we can no longer overlook these obvious things. Thank you for the patient listening.
That is Dr. JP. Exactly 30 minutes. A role model for a speaker, sticking to time. I think he had discussed what areas to be discussed on this obvious. He has discussed all the comorbidities. Probably I may add something like the things which you are overlooking when you are treating a patient. You have made the diagnosis, you have picked up the comorbidities, you have predicted the prognosis, and you have planned the management. You are treating the patient, but what are the usual things which we are overlooking? There is one thing which I had in my mind, like mainly I think fluid. I am very much interested in fluid, all the other things we have said. And that's the one thing which has made a big difference in management of patients with resistant heart failure. And fluid intake output, we quickly say that we have to restrict the fluids, but we don't spend time to tell what exactly is the volume. 1.2 liters, 1.5 liters, they don't know. And in the ward, to be very frank, I seldom 100% rely on the intake output chart. And what I personally recommend is look for a daily weight recording, which is more objective, more reproducible in the same balance than blindly taking intake. I'm sure my personal experience in the various institutions which I have worked, medical college, government, private medical college, prestigious institutes, there, sisters എഴുതും എത്ര തവണ മൂത്രം പോയി 4 തവണ മൂത്രം പോയ 400 into 4 or 300 into 4. Not in the ICU, I not mean. എത്ര കഴിച്ചു 7 ഗ്ലാസ് കഴിച്ചു 7 into 200 they write. So that is one thing which I thought was the most obvious thing we miss in the treatment of heart failure, apart from what you have said in diagnosis, planning the management, and predicting the mortality. Then you should look for hyperdynamic circulations. Obviously, drugs, we have seen enough cases. Drugs contributing to heart failure and making the heart failure resistant. We have discussed about OSA. That's all. But now we'll take some of the questions which have been asked. Initially, I was a little depressed because there were no questions coming up for the initial 15 minutes. It indicates either JP is very impressive, they know everything, or they are interested in general medicine than in specialty. Certain things are simple, which I'll take up. The difficult question, I will hand it over to Dr. JP. Experience with the DAPA, I think he has already discussed. Personal experience, it is too short a time to express our personal experience. We have enough data. So that question can be easily answered, because all the answers in an academic session should be based on studies, either international or our local level. Postgraduates have done some studies, as previous speakers have said. Then one question was on dobutamine in heart failure with preserved ejection fraction. Can it be used when the BP falls? Now, it is not for heart failure, and there is no role for dobutamine. You should find out why the BP fell down. In heart failure with preserved ejection fraction, if the BP has fallen down, we have to think whether you have given excessive diuretic, vasodiet, the iatrogenic problems, fluid intake. These things are more likely because the myocardial systolic function is normal. And given dobutamine to improve the myocardial performance is not recommended. Then I will put the difficult questions to you. One is CHF patient developing stroke. What is the drug to use to reduce cerebral edema? That is one of the questions you can answer, or a physician or neurologist also can contribute.
I think it's a difficult question. It's a difficult question because we all know that a mannitol, which is the drug which is used to reduce cerebral edema, can worsen the heart failure. So, but if you look at the data on mannitol, although the theoretical risk of worsening the heart failure is there, whatever meager data we have sent out, it is all mostly theoretical. The real worsening of heart failure with mannitol is not very common. That is one point which I would say. But if you ask me, my drug of choice will be diuretics to reduce the cerebral edema, and not mannitol as the first choice. Diuretics would be my first choice.
Suppose the heart failure is fairly well controlled. We have treated, heart failure is under control, patient develops atrial fibrillation and the patient develops a stroke. No, I'm not cornering you.
If there is cerebral edema, even if the heart failure is controlled or reducing the cerebral edema, I may be giving diuretics, and second choice would be mannitol.
Okay, fine. Or you will combine mannitol with diuretic? Because mannitol is better to reduce cerebral edema. This is not cornering you, just I am asking my doubt.
My first choice will be diuretics.
Diuretic, okay, fine. Now the next question is, in patient with heart failure preserved or reduced ejection fraction, the second question was, is ARNI your first choice? Angiotensin receptor neprilysin inhibitor. Is it your first choice?
It will not be my first choice. It will not be. It will not
Why?
be. Because the data on ARNI in HFpEF, I think the question is on HFpEF.
No, reduced ejection fraction.
Reduced ejection fraction.
In reduced
ejection fraction, I would say there is some data coming. It can be initially itself started in patients even with NYHA class 2, but such data is too meager. So it will not be my first choice in a patient with HFrEF.
In heart failure?
Too meager data.
Usual patients coming with heart failure. Say a patient comes with heart failure. What we are seeing, not asymptomatic. Heart failure symptom which you have discussed. Will you use, that was a question, ARNI, ACE or ARB? Take it more academically.
First choice will be practically, I will be starting ACE inhibitors and or diuretics.
Yeah.
It will not be ARNI as the first choice.
I also prefer ACE inhibitors as the first choice. If can't tolerate ARB, and ARNI if the patient is not responding, because it's a very costly drug, limited data, the other time-tested drugs. But if the patient is well educated, they are going through the net, all those things I will discuss and I may start. But as JP said, it may not be the first line drug in management of heart failure in majority of our patients. Okay, you agree with me?
Yes, yes, of course.
Then next is for heart failure with treating beta blockers. Which beta blocker will you prefer?
That is already we have enormous data on the beta blockers in heart failure. The drug tested in heart failure are, one is metoprolol extended release, that is succinate. Second is the carvedilol, and third is bisoprolol and nebivolol. These are the 4 drugs which
So your order
the,
will be
my order will be metoprolol, sustained release first, and carvedilol. Both I would say equal. Both I would say equal. Carvedilol, especially in diabetic patients, and some patients may have some advantage. But in general, I would be preferring metoprolol, sustained release, and probably in diabetics and other subsets, I may be preferring carvedilol.
Okay.
And the third drug of choice will be bisoprolol, and lastly nebivolol.
Okay, leave it to the physician.
Yes.
If I am prescribing nebivolol, you may not change.
I may not change.
Okay, that's it. Okay, the next is salt restriction in hypertension and heart failure. How will you advise the patient? That was a practical question. How will you advise? You say salt restriction, ഉപ്പ് കുറയ്ക്കണം. അതെങ്ങനെ പ്രായോഗികമായിട്ട് കുറയ്ക്കും എന്നുള്ളതാണ് ഈ ചോദ്യം വന്നിരിക്കുന്നത്. Very difficult question.
That is also a difficult question. I think sir will be better, but I would say my opinion.
I said
salt reduction, and we are not measuring the salt and telling the patient. So what practical thing is that that means adding salt subsequently on table. Second one is that salted foods like our uperi, papadam, all these things can be reduced. And actually, I would say total reduction of salt is deleterious also. It has been shown that total reduction in the salt can worsen the morbidity as well as outcomes. So just reduce the foods which are having high salt content, like don't add on-table salt, avoid papadam, uperi, and the things which have a high salt. I would like to have sir's opinion also.
I fully agree with you, because I know that we have been working together for years. Even after medical college, we have been discussing, so no difference of opinion. But basically, our normal diet, vegetables, all those things, if you take, it will contain around 2.5 gram of salt. But the question becomes a little more difficult when a patient we are treating with heart failure develops hyponatremia. That will be more relevant here in this discussion. Hyponatremia in a patient with heart failure, you are treating the patient develops hyponatremia quite often. How you are managing? Very difficult issue, but
heart failure and hyponatremia.
Yeah, in the what? You are treating heart failure, patient develops hyponatremia. Serum sodium is 180.
Mandating treatment.
No, you have to. We have to answer.
The first thing is that I would look at the diuretic, because although the hyponatremia part is not much different with torsemide versus furosemide, the overall the electrolyte abnormalities are lesser with torsemide. So I would first switch over from furosemide to torsemide. And second option, whether to give a tolvaptan versus other molecules in natremia. Tolvaptan may not be my first choice, because tolvaptan, the data in heart failure is not very rosy. So first I will switch off from furosemide or other diuretics, and if there is a combination of diuretic like metolazone plus furosemide, which is notorious to cause this electrolyte abnormality, I will take off the metolazone, and if furosemide is there, I will convert to torsemide. And one data which has come, especially in hyponatremia with heart failure and some renal dysfunction, is hypertonic saline has been found to be a good choice. Although we all think hypertonic saline is not a choice in a hyponatremia patient, it has one of the recent data has shown that hyponatremia in a patient with renal failure, hyponatremia, and heart failure, this hypertonic saline is a good choice.
Okay, I think we had enough time. A few more questions have come. To restrict volume and sodium, I think that's most important. As I think if Dr. Jayamar was there, he could have contributed greatly. Fluid, whether it is hypervolemic, bulimic.
Sir Jayamar, ഒരു മിനിറ്റ് പറയാമോ സർ?
Please.
Sir, in heart failure and hyponatremia, നമ്മളിപ്പം കേട്ട് വന്നു കഴിഞ്ഞാൽ it is sodium അല്ല അതിനകത്ത് issue.
Water.
Any situation of hyponatremia, always sodium in relation to water ആണ് നമ്മൾ പറയേണ്ടത്. So whatever be the situation, is there any role of increased water absorption? That question you should answer. And as in case of cardiac failure, as in case of hepatic failure, it is not the kidney or electrolyte or furosemide. It is the severity of the heart failure, severity of the hepatic failure that it is. Because intravascular depletion, that will produce a neurohormonal changes, that will produce RS activity, ADH activity, like that. There will be excess anti-diuretic hormone in this situation. So you have to basically control the intravascular situation. JP was telling about hypertonic saline. That may be one of the reasons for the better outcome with the hypertonic saline in this situation. So it is for the kidney. It is the intravascular depleted state that will determine the hyponatremia. Then about your sodium. Anyway, we are discussing a serious condition like heart failure, and survival is an important. You have to say the strict control of the sodium. What I used to do so for my patients regarding sodium is that everybody is familiar with the teaspoon. It may contain about 2 to 3 grams of food. You take that much amount of salt because it is not a single, it is with your life you are playing. So that is the thing. And as you said, avoid uperi papada achar, onakamin uperi in the fish. That is the thing, sir. Simple.
But one thing I want to add is about ACARB that can produce hyponatremia. So
Yeah.
that also should be kept in mind. I think we are running short of time. Just to quickly go through that, that is role of cardiac contractility modulation, purely academic for postgraduate discussion. Bakery goods containing soda bicarb, Sajid from Sajid, this thing, but we should, JP has said that to take ordinary food. I think we had a wonderful session. Thank you, Dr. JP, for the presentation, answering the question and mutually communicating with me also. I'm sure the audience would have been extremely happy with you. And I should congratulate Sangamitra and Cyril and the whole Fiesta team for the excellent organization and the way have conducted. Thank you very much for inviting me also. Thank you.
Thank you, sir. Thank you all.